This lecture is on nerve injuries following upper limb fractures. The objectives for this lecture are to be able to do a thorough assessment and then provide the physiotherapy management for nerve injuries in upper limb fractures. With any injury in the upper limb, especially fractures, it is imperative to do a thorough neurovascular assessment to look at the three major nerves running through the upper limb: radial nerve, ulnar nerve, and median nerve. Remember the different classification of nerve injuries according to Seddon's: a neuropraxia, where it is a pressure on the nerve with temporary decrease in sensation and motor power; an axonotmesis, where more of the nerve is injured; and a neurotmesis, where it may even be lacerated and no sensation and motor power for that specific nerve in its distribution is found in your assessment. Let's start with the radial nerve. When the radial nerve is injured, what will you assess and what will you find as deficits in the hand? Let's look at the muscle supply first. The following muscles, depending on the area of the fracture or the area of the nerve injury, will not work. Firstly, the triceps, extending the elbow, brachioradialis, your extensor carpi radialis longus, your ECU, extensor carpi ulnaris, EPL, extensor pollicis longus, extensor pollicis brevis, both extending the thumb, abductor pollicis longus, moving the thumb away from the palm, EDC, extensor digitorum communis, extending the metacarpal phalangeal joints of the fingers, extensor indicis proprius, extending your index finger, extensor digiti minimi, extending your little finger, and your supinator. How many of these could you remember? Looking at the sensory supply of the hand, you will see the pink part supplied by the radius. The ulnar side is the medial 1.5 fingers, volar and dorsal surfaces. The median nerve is on the volar surface, 3.5 fingers on the radial side, as well as the tips of the fingers on the 2 and 3.5 radial side fingers on the dorsal side. The presentation of the hand after radial nerve injury is a dropped wrist. If it's a high radial nerve injury, the triceps will also not be working, so no elbow extension. There are various different causes for this listed: humerus fractures due to axillary crutches, Saturday night palsy, or fractures where during trauma. So the forearm is also pronated due to the lack of supinator working. Also reduced grip strength. The ulnar nerve supplies the FCU, flexor carpi ulnaris, flexor digitorum profundus of the ring and little finger, deep head of the flexor pollicis brevis, and many of the intrinsic muscles inside the hand, as your adductor pollicis, palmaris brevis, also your adductor digiti minimi, opponens digiti minimi, flexor digiti minimi, that is your hypothenar muscles, your third and your fourth lumbrical, and your dorsal and your volar interosseous are all supplied by the ulnar nerve. An ulnar nerve injury depends on where the nerve is injured. A high lesion is where there's been trauma at or above the elbow level or the cubital tunnel compression. That is seen as a high lesion. A low lesion is at the wrist level laceration or the Guy's canal compression, so anything below the elbow. Presentation: classically a claw hand with the metacarpal phalangeal joint in extension, and that gives you that clawing and the flexion of your IP joints. Also remember the loss of sensation on the ulnar 1.5 fingers. They lose, patients sustaining ulnar nerve injuries lose deep intrinsic hand power, and that's your finger ab and adduction. With your interosseous not being there, is weakness and clumsiness in the hand, and a Frohman sign as well. In these images you can see the atrophy, top left on the volar side of the hand due to the muscles not working. You can also see a scar present running from the carpal tunnel into the hand. Number B, image B, is a claw sign as well as to its right. And then a Frohman test is where, because of a lack of adductor pollicis muscle supplied by the ulnar nerve, because the adductor pollicis is not working, the patient is using the flexor of the thumb, flexor pollicis longus, to grasp the piece of paper while somebody's trying to pull it out, and that is a positive Frohman sign. Let's recap the median nerve supply to the muscles. Supplies the flexor carpi radialis, pollicis longus, FDS and FDP to the index and middle finger, flexor pollicis longus, flexor pollicis brevis, abductor pollicis brevis. Opponens pollicis, pronator teres, pronator quadratus, and your first and second lumbrical muscles. As in the ulnar nerve injury, the median nerve injury is also classified as a high or a low lesion. High lesion with the injury at or above the elbow level, a low lesion, a lesion below the elbow and the wrist level, over the carpal tunnel also, with compression, most commonly known as carpal tunnel syndrome. The presentation of a patient with a median nerve injury is an ape hand deformity, benediction sign, loss of sensation on the radial 3.5 fingers, loss of thumb opposition and abduction, also weak and clumsiness in the hand. Here you can see the benediction sign on the left as well as the ape hand on the right. In the presence of a peripheral nerve injury, the medical team will make the decision to do a primary repair as operative management during an exploration, or they will decide to follow a conservative management route first and observe and wait and see what the recovery of the nerve is like. For conservative management, always incorporate pain management. Splinting, make sure if it's a radial nerve injury that there's a wrist extension splint, anti-claw splint for ulnar nerve injuries, and there are various types of different splints in the slide. Physiotherapy, vitally important to maintain the range of motion and also to strengthen the muscles that will potentially work for tendon transfers. Also refer and include the necessary multidisciplinary team, for instance social workers, to look at grant or insurance, as these injuries often take a prolonged time to recover, if it recovers at all. In your physiotherapy assessment, after conservative management, do a thorough subjective assessment and objective assessment. Look at range of motion, as we don't want the fingers to become stiff while the nerve is recovering. Consider sensation, and also to educate the patient with using hot water at home where they might be burning or cooking, and that they need to look at different ways to make sure that they don't sustain burn wounds in the area where there's no sensation. Optimize the muscle strength of the muscles that are innervated. Assist the patients to adjust their ADLs and do regular reassessments to monitor any signs of recovery. Education is vital, and also to tell the patient about the prognosis and the time of nerve repair. Let them have a home exercise program also to do at home to maintain range of motion, strengthening. Looking at the surgical management following a nerve injury. Firstly, a primary nerve repair. Then a release of the compression of the nerve, for example, a carpal tunnel syndrome. And then if there's still no recovery, past the expected time of recovery of that nerve, then tendon transfers will be decided on. Either radial tendon transfer, an ulnar for Zancoli lasso technique, or a transfer of your extensor indicis proprius to adductor pollicis, so that you get that metacarpal phalangeal flexion, or in the instance of a median nerve injury where the patient does not have opposition of the thumb, opponentsplasty, and a transfer of a brachioradialis tendon to extensor carpi radius longus or extensor carpi radialis longus to give flexion of the thumb, so to act as a pollicis longus transfer.